Go ahead, Tim.
Hi everyone, and welcome on behalf of IPP and Family Planning 2020 to this webinar on engaging men and boys in family planning. Thank you very much to everyone for joining, wherever you're joining from. Good morning, good afternoon, good evening. We are thrilled with the level of participation. We've had 415 people register. I imagine some people will join late, but we are going to get started. My name is Tim Shand. I'm the moderator for this conversation. I'm the Vice President of Advocacy and Partnerships at Promundo. I've worked in the area of men and sexual and reproductive health for some time, before Promundo at Georgetown's Institute for Reproductive Health that we'll hear from on the webinar, also through the International Planned Parenthood Federation and WHO. So thrilled to join you. Next slide. So we've got three really exciting contributions to share with you on this webinar, and our overall objectives are firstly for you to have a better understanding of the Male Engagement Planning Guide. If you haven't yet seen the HIP Strategic Planning Guide on engaging men and boys in family planning, there is a handout section to the right of your screen, and the guide is available currently in English, Portuguese, and Spanish, and French will be coming soon. Please do download that planning guide and have a look at it. It's a fabulous resource to better aid your programming around male engagement, and we will talk through the guide in a moment. And we also want to share implementation successes and challenges in engaging men at both the global and the country level. And as I say, we'll hear from two global slash country perspectives, and then we'll have one perspective specifically from the Tanzanian context. Next slide. So before we talk specifically about the HIP guide, I want to ground us in why are we having this important conversation? Why is it necessary to strengthen our focus on engaging men and boys within family planning? And I think one of the things that we see consistently is we know the global unmet needs that doesn't go away. The commitments we now have in the 2030 agenda, the 200 million women who want to avoid pregnancy each year but are not using contraception, the billions of people we know that have inadequate access to sexual reproductive health services. And we often focus more, I would argue, on the provision of services and less on the barriers that male norms, attitudes, and gender inequalities provide for both men and women, boys and girls, to access the services and support they need. And you'll hear some excellent examples on this webinar on how, in particular, we're foregrounding the challenge of norms, attitudes, and inequalities. And we've had for a long time, and we have now a growing evidence base that male engagement works. We know that this is an important principle. Many of us have been working on this for some time, but it's not just the right thing to do, it's the effective thing to do. And we know that thoughtful, gender transformative, well-implemented male engagement works. And again, we'll hear some examples from that. But we really do have an increasingly solid evidence base for this approach. And we've had, since the International Conference on Population and Development, rigorous, pretty ambitious targets at the international level, and then subsequently reflected at the national level around the engagement of men and boys in family planning. However, despite these significant commitments that both the international and national governments have made, I would argue that our interventions in this area generally remain short-term, are limited in scope and scale, and are often peripheral. And you'll hear again some excellent examples of this work, but it tends to remain within particular pockets, championed amongst specific individuals, but rarely taken significantly to scale or integrated within national health systems or across national approaches. And so I would encourage us to think through how we do that and push that forward. And I think it's important that we ground this conversation in principles, the principle in particular of women's autonomy, the fact that engaging men in the context of family planning, if not done effectively, could do harm, and that we need men not in charge of women's sexual reproductive health decisions, but as full equitable partners. But we do have collective will, and there are exciting opportunities. We've got 126 people who are now on the webinar, so let's work together and push this forward. Next slide. I think you may be aware, and if you haven't, please do look at the recently launched Guttmacher Lancet Commission on Sexual and Reproductive Health. In particular, it foregrounds the fact that men as partners, both in sexual and reproductive health for women and girls, and also for their own use, remains one of the populations where greater progress is necessary. And in particular, if you look at the evidence around where we've come since ICPD, since 1994, we've seen significant increases overall in contraceptive uptake, but only a 2 percentage point increase in global male methods. So we have a long way to go. Male methods remain, since they were 20 plus years ago, as only a quarter of overall contraceptive use. And so that's the challenge we have before us as we think about how we meet these ambitious targets through FP 2020 and beyond. Next slide. I want to introduce the HIP strategic planning guide to you now. It has 4 particular steps. Several of us on the call and others were involved. And I would really commend this document to you, particularly as you think about strengthening or building your own work. So step 1 of 4 within the guide is the importance of defining your behavioural aim within your intervention. And again, we will hear about this on the webinar, and specifically thinking through the behavioural outcomes and the indicators to track those outcomes. Next slide. Once you've been clear, once you've identified your behavioural outcomes, the HIP guide then takes you through step 2, which is the importance of assessing men and boys' knowledge and attitudes relating to reproduction and contraception. We know that globally, sexual and reproductive health information tends to typically target women and girls. We know that the barriers that men's and boys' misinformation provides to their use and often to preventing their partners or others from accessing contraception. So it's important to be aware and put in steps to address that misinformation, as we will also talk about on this webinar. Next slide. And then step 3 is looking at the centrality of gender norms as it affects male engagement and family planning. And not only thinking through, as we tend to often talk about, the negative impact of these gender norms, and in particular patriarchy and how it manifests itself both as a control of women's bodies, but also how patriarchy affects the behaviour of men and women together. But also the necessity of fostering and supporting more positive male gender norms. And again, we will hear about the importance of thinking this through in our interventions on the webinar. Next slide. And then the last step is understanding all that context, then identifying the programming approaches that engage men and boys, and really thinking through, in particular, what are the most appropriate levers of change, the most appropriate places in which to intervene and try to shift this work. And thinking through especially where do men prefer to receive SRH information, as we will also hear discussed today. Next slide. As we think about our male engagement work, I want to encourage you also to look at the high impact practice briefs and the high impact practice websites, www.fphighimpactpractices.org. And there are a number of both social behavioural change and service delivery high impact practice briefs on that website that could be used and tailored to strengthen your approaches to engaging men and boys. This table is not very easy to read here, but it's on the HIP guidance for male engagement, and would encourage you to look at that, and in particular the ticks here identify where there is most potential to use the existing HIPs to support your male engagement work. Next slide. The strategic planning guide also provides a number of tips for implementation experiences, and we again will hear many of these from the presenters today. Next slide. I want to say 2 things about Promondo's own work. Firstly, to highlight that as part of trying to shift the international paradigm, in particular to strengthen the fact that we do have international commitments, but these have not necessarily been translated into the targets or indicators to strengthen the focus on engaging men within SRHR and family planning. We don't have a global bold target, for example, or an indicator to increase men's uptake of existing methods. And then as a result, that often isn't translated into national commitments within, for example, national family planning policies and guidance. So we've developed at Promondo an advocacy brief, which was revised through a consultation meeting in Washington, DC, and we've just shared the updated version of that, which outlines the important guiding principles for this work, 10 priority action areas, including the how do we increase and speed up the use of existing male methods, how do we expand the contraceptive technology mix, including new male methods, how do we support men's greater involvement as partners within SRH and as advocates, including as advocates for women's access to safe abortion. We'd encourage you to look at that. It will be available on our website soon, www.promondoglobal.org, which is kind of hidden from the bottom of the slide. And we will also be using that to inform a broader report with additional detailed analysis called a landmark report on gender, men and SRH that we will launch at the International Conference on Family Planning, including looking at DHS data amongst others. And lastly, we're doing an analysis of family planning costed implementation plans and the extent to which they currently engage men or not, and we'll be happy to share that with you. We'll be looking at as many of the costed implementation plans as possible. And then next slide. I also wanted to share with you the results and encourage you to look at these if you haven't yet, of our randomized control trial of our gender transformative parent training intervention within Rwanda, in particular targeting fathers and their partners around maternal, newborn and child health and the importance of male caregiving. It's now available on PLOS ONE and can share the article with you. I think the important thing for us was thinking about this work is not only an entry point to shifting norms and attitudes and behaviours around family planning and sexual reproductive health, and we were pleased to see an uptake in family planning use and shifts in antenatal care behaviour, again, greater male support around that. But also we saw reductions in intimate partner violence and violence against children. And how do we think comprehensively about these approaches? And how do we really, as you will hear in this webinar, foreground the importance, particularly in parent training, which tends to often target mothers, of working with fathers and mothers together in gender transformative ways. And we know, again, as we see here, the evidence of impact in doing so. Next slide. So today's panelists, we have Erin Milkey from USAID, we have Rebecca Lundgren from the Institute for Reproductive Health at Georgetown, and we have Albert Komba from Japaigo in Tanzania. Three very distinguished professionals and speakers on this issue, and really excited that they'll be able to share their thoughts and experiences with you. You'll see that there's a question box. We'd like you to please share your thoughts and questions if you have them. Type them into the box. We won't take any questions during the presentations. We will take all questions at the end, and I will and the team will sort them out as we go along and come back to them. But we're really keen to provide space for you to share your thoughts, so thank you. So we'll move firstly to Erin.
Great, thank you, Tim, and greetings to everyone, and thank you for this opportunity to share USAID's perspective on engaging men and boys in family planning. Next. All right, and next. As a global community of practice, we have an uneven history of engaging men and boys. Historically, family planning programs have primarily focused on women as beneficiaries and have tended to view men as obstacles or barriers, or have had deep skepticism about their willingness to participate in family planning use. At USAID, we are committed to doing more to engage men, but not at the expense of women and their needs. Programs and interventions must always consider how to engage men without infringing on the rights of women. Our focus is on emphasizing the role that men can play, not only as supportive partners, but as active users of voluntary family planning and as agents of change around family planning and gender equality in their families and communities. At the core of this, we want to catalyze a global paradigm shift where men and women are routinely thought of as informed contraceptors and consumers of voluntary family planning and reproductive health services. This includes expanding men's role in reaching FP 2020 goals and incorporating men's data in other global family planning goals and models. Next. So why should we engage men and boys? Studies show that men can be a stepping stone to couple contraceptive use. Engaging men and boys can also help transform inequitable gender norms that act as barriers to voluntary family planning use. Evidence also suggests that when men know about and support family planning, it can influence their partner's desire to use contraception and improve couple communication about family planning. Also, men's attitudes, values, and behaviors related to relationships, gender roles, body literacy, responsibility for reproduction, and other health-seeking behaviors are formed during adolescence. For this reason, age-appropriate male engagement should start early. Next. Next slide. Thank you. We also know that in many contexts, men hold favorable attitudes towards contraception. A review of demographic and health surveys conducted between 1994 and 2006 found that a significant proportion of men in 28 sub-Saharan African countries approve of using contraception to avoid a pregnancy. Neglecting to engage men and boys is a missed opportunity to tap into this valuable supportive resource for voluntary family planning use. Next. More reasons for investing in male engagement include the following. Where men are gatekeepers, their participation and support are crucial. Where men are already supportive of family planning, their engagement can further support women's well-being. Reproductive health, for the most part, remains women's responsibility or burden. Increasing men's involvement reduces the burden on women and increases gender equity in family planning use. Another reason is to engage men in the interest of improving their own reproductive health and increase gender equality. Today, the proportion of global contraceptive use of male-controlled methods, meaning condoms, withdrawal, and vasectomy, is about 21%. Although this percentage is influenced by women's uptake of family planning, we consider this to be insufficient, albeit complementary family planning use. Either as users or supportive partners, men should be an integral part of future efforts to increase voluntary contraceptive uptake. At the same time, globally, we have seen an increase in the number of couples that want to limit, while the age when couples have reached their desired family size and are choosing to limit childbearing is getting younger. Finally, engaging men in family planning also contributes to voluntary contraceptive uptake and the sustainability of programs. Next. USAID supports activities that, one, set the stage for boys to become future voluntary contraceptive users and supportive and responsible partners, husbands, and fathers. Two, increase men's knowledge of and demand for voluntary family planning products and services. Three, strengthen the capacity of health systems to deliver quality voluntary services to men, boys, and couples. Next. We also support programs that provide men and couples with a broad range of methods that meet their contraceptive and family planning needs at different life stages, including making voluntary vasectomy a viable option. Also develop national policies and guidelines that include men and boys as family planning clients and contraceptive users, and scale up proven interventions that seek to promote equitable gender norms and roles for men and women. And lastly, fill knowledge gaps by collecting more data on men and adolescent boys. Next. In summary, men have an important role to play in family planning, particularly in deciding with their partners the number of children they want to have and the contraceptive method they choose to use. Men sharing responsibility for family planning improves access and use of contraception, equalizes commitment to health, and improves overall well-being. Moreover, it can increase modern contraceptive use, promote shared decision-making between couples, and help shift the belief that family planning is only a woman's issue. We hope this new resource, available in Spanish, Portuguese, and English, will be useful to program managers and other stakeholders looking to invest in male engagement to improve men and boys' reproductive health and increase family planning outcomes. I would like to add that coming soon, USAID will publish a document called Essential Considerations for Engaging Men and Boys for Improved Family Planning Outcomes. While intended for USAID staff, it will also be available to implementing partners, donors, and stakeholders. Thank you.
Great, thank you very much, Erin. And we move now to Rebecca Lundgren.
Good morning or good evening, everyone. I'm really excited to be here with you this morning or this afternoon and share some reflections on our organizational learning over the last 2 decades of the work that we've been doing involving men. Next slide. So IRH began working with men in about 1997 when we were working on developing the standard days method, a couple method, and we realized how important it was to work with men in couples. Ever since then, we've continued the task, and you can see on this slide the projects that we've been working with which have male involvement components. They've spanned the globe and addressed men across the life course. Our major outcome is improved family planning use, but these projects also address gender-based violence, gender equality, and violence against children. All of these projects were conducted in collaboration with partners around the globe, and specifically Save the Children, Plan International, CARE, and Tear Fund. Next. So today I'm going to present 8 lessons learned, which are really relevant to the presentations you've already heard, but a little bit more of a reflective tone looking back. I'll kind of shape these throughout from formative research to program design through scale up. Next. So we all hold our own assumptions about what men want, need, and would prefer, but sometimes we find research shows us that there's a difference between what we think men want, what men and boys, providers, their wives, their partners want. So what's really helpful is some formative research to help us look beyond our often unexplored assumptions about men and boys. Next. The Real Fathers, for example, program is based on formative research conducted by Save the Children with young fathers. It uncovered a number of motivations for men to change their behaviors, to decrease alcohol use and improve partner communication and move into nonviolent conflict resolution. Next, please. These motivations were then used to develop a mentoring program to respond to men's needs in this context for respect and guidance from their elders. Next, please. It's also important to think about materials. I find that we often design materials from a woman's perspective. Maybe that's because we know best or what we're used to doing. And an example of this was a midterm evaluation in Benin, when we found that men felt their perspectives were not well addressed in our dialogue materials. To address their concerns, we developed new storylines and tweaked the materials that we were already using. Next. We had similar results in work with family planning or couple counseling in US family planning clinics, where we found men reacted negatively to the first draft of our materials. They told us it's not enough to say support your partner. You need to be direct. Tell us to buy the condom, take her to the clinic, or whatever is specifically needed. Next, please. So as Tim and Erin have already discussed, underlying male engagement work is the issue of power dynamics and the influence of masculinities. All of our programs have addressed these, even if only in small ways. Next. A few have tackled social norms, for example, working in faith settings, which we know have a fundamental role in shaping gender roles. Next. Current project underway in Kinshasa is the Transforming Masculinities program. We're conducting a RCT of this program, which addresses gender norms through faith structures. Next, please. But it's not just about addressing gender attitudes and gender norms. It's also about applying our understanding of gender dynamics to the programs. Gender synchronization provides us a framework to do that. So for example, in the program in Karamoja, Irian, they use a synchronized schedule for male and female peer groups to learn together and then to come together to teach each other, providing an opportunity for gender synchronization. Next, please. So despite my best intentions, and probably some of those of you on the phone or on the call, we often fall into the trap of thinking about men as static and one-dimensional. Next, please. Men, like women, are not monolithic. They have diverse needs and perspectives, which are affected by their class, race, age, and ethnicity. Next, please. Thoughtful research can help unpeel multiple layers of masculinities, such as qualitative research in Benin, which revealed family planning enabling masculinities, next, as well as inhibiting masculinities. In fact, many of the men we spoke with articulated both at the same time. Next, please. As we begun to better understand where men are and what their needs are, we can segment them and approach them more effectively. Take Real Fathers, for example, which I already mentioned. It was designed for a very specific group of fathers, first-time fathers in a post-conflict setting. Although there's a lot of excitement about scaling up and expanding Real Fathers, it may not be successful in a different context with different motivations and men's needs. Next, please. So during our work expanding access to the standardized method, we've encountered many barriers to engaging men in couples. For example, during monitoring visits, program staff often would tell me men aren't interested, they're not around, they're too difficult to reach. Yet when I asked further and we had longer conversations, I found that their outreach efforts were limited to daytimes when men were in the fields or in the factories. Sometimes men were outside the clinic or in the waiting room, but they weren't making an effort to reach out to them, or there were no men on staff or no materials for men. Next, please. So in this process, we learned a few simple things to overcome these barriers. Working through men's networks was one of them, and the other is making organizational accommodations needed. People may need to work evenings or weekends to reach men. Next, please. Research tells us that men receive information from male networks, and we were able to successfully test strategies to do so through cooperatives, microfinance groups, reaching men through community development committees, next, and also through water and sanitation programs, where men are typically quite active. Next, please. Another way to meet men where they are is to consider where they are in the life cycle, taking into account the individuals and forces that influence them at each phase of life. Next. Growing Up Great is a program implemented by Save the Children in Kinshasa. It explicitly targets multiple levels of the ecological system to develop a supportive environment to promote adolescent health. Next, please. Social learning and influence theory tell us that people learn new ideas and they're influenced to apply them by discussing them and comparing them within their networks. Next, please. This quote here gives you a little bit of a hint about why social networks are important. And we found that identifying and engaging men's reference groups can help us to achieve and sustain change. Skip, please. So Tekpon and Jikwago, for example, is an intervention designed on social network principles, which was piloted in Benin and is now being expanded within Benin and also in Mali. It showed that men who believe their network partners use family planning were 2.5 times more likely to use family planning themselves, and also showed positive effects of systematically engaging social networks in order to address unmet need for family planning. Next, please. So moving on to the lesson 7, this is a sticky question, and it's been alluded to already by both speakers. So who are we trying to benefit? Is male engagement a means to an end? Is it a means to help women? Or do men matter in their own rights? Next, please. This quote from a young man in northern Uganda reflects one man's opinion on that perspective. He calls it female planning, not family planning. Next, please. Unmet need is a key indicator for our programs, for our family planning programs. However, it is female-centric and biologically driven. Research in Benin showed us that actual and perceived need varied substantially between men and women. And we found that it was really important to understand unmet need from a man's perspective and develop programs that met their concerns. Next, please. Another way to reach men is to expand choices to include male and couple methods. Vasectomy, condoms, fertility awareness methods. Our work suggests that many men are engaged in family planning. The bullets on this slide are from women, female SDM users, who reported that 90% of them reported that their partners were actively engaged in method use in the ways on this slide. Next, please. Training men as providers is also an effective way to engage men. Here you see a male volunteer who was trained by Care India to provide family planning information and counseling. beyond their previous role, only focusing on STIs. Next, please. Men can also be engaged as advocates, spreading information through their networks and facilitating group discussions about family planning and gender. Next, please. So my final and probably most important lesson is avoid pilots to nowhere. We need to reach enough people in a sustained way to make a real difference in the world. There are many pilots, but few are scaled. From our early work on the Standard Days method and our subsequent work scaling it up, we've maintained a focus on scale up. Next, please. For example, the Real Fathers Project, we worked with Save the Children to expand Real through integration into cross-sectoral programs. Next. We also worked to expand GREAT into the portfolios of community organizations in northern Uganda after the pilot was coordinated by government structures. Next, please. So we do this by applying scale-up criteria inspired by the ExpandNet consortium that you see here on the slide. We found it takes continual reflection and discipline to ensure that our interventions and implementation meet these scale-up criteria. Next, please. So we attempt to develop materials that are low resource, locally made. For example, the two you see here is a great game board in Uganda and the Pragati puzzle from the FACT project in Nepal. Next, please. And we also resist the temptation to put into place new structures or activities that require intensive training and support unless they're absolutely needed. Next, please. Finally, activities that are engaging and culturally rooted are naturally more likely to be used and sustained in the communities where we work. Here you see an example of EDN Community Theatre in Karamoja, Uganda, building on traditions of oral history and storytelling. Next, please. So here you see the 8 lessons. I think they're all very relevant to our strategic planning guide. And my hope is that we can take heed of these lessons to keep working together to move our work forward to achieve our vision of a healthier, more equitable world. Thank you.
Great, thank you very much, Rebecca. A reminder to everyone to submit questions. We haven't had any questions yet. The question box is on the right of your screen. You just had 2 fantastic presentations, and we're moving on to our last presentation now from Albert Komba.
Right, so greetings everyone. I'm very pleased, next slide please, on behalf of Japaigo, who is leading the Sauti project in collaboration with PACT and Gender Health and the National Medical Research Institute. We're very pleased to share with you some field experiences on how we're engaging men and boys in family planning. Next slide please. So we are a 5-year project, purely HIV combination prevention program, but integrated with family planning, covering about 60% of the country. And we're working very closely with the Ministry of Health and the Tanzania Commission for AIDS. And part of our work also gets implemented through civil society organizations. And we have about 18 of them. Next slide, please. So as I mentioned, we are a combination prevention program. And we have behavioral interventions which are peer-led, using curricula, focusing on some key and vulnerable populations. I'll mention them in the later slide. And then we also have economic empowerment interventions. These are purely targeting adolescent girls, young women, age 15 to 24. But for the purpose of this discussion, we have interventions that are biomedical in nature, and this includes the family planning, HIV, integration. We also have other interventions, pre-exposure prophylaxis, community IRT, STI, and the like. And the goal of this program is to ensure that we're putting clients at the center. Men are also included as part of the beneficiaries, and provide them services at the community level, and have very strong linkages with facilities. Next slide. So being a community program, as much as we would have wanted to give a full range of family planning services to both men and women, the Tanzania government, through the Ministry of Health, gave us a list, or allowed a list of family planning methods that we are allowed to provide. So this ranges from condoms, pills, injectables, and implants. And any client who requires IUD for females, we have to escort them to the nearby facilities. And men who require vasectomy, but also women who require long-acting permanent methods, we also refer them. Next slide, please. So this slide summarizes or illustrates the different range of family planning focused services for men and women. So we have adolescent girls, young women, female sex workers, and other women who are living in in the hotspots. So for these populations, we provide family planning, demand creation, IC materials, condom demos, and services. But also, as I mentioned in the previous slides, we give them pills, injectables, implants using trained providers and do referrals for IUDs and long-acting permanent methods. For the men whom I would like to break down this group a little bit, our men are categorized into partners of adolescent girls and women, as you could see in the earlier line, partners of female sex workers, other men living in the hotspot. So this could be folks working in the timber plantation, fisher folks, etc. But also we have men who have sex with men. And in the context of Tanzania, some of the men who have sex with men have heterosexual partners, so we also target them. And for these particular groups, we provide FP demand creation, education materials, condom demo distribution, and also referral for vasectomy, should be not long-acting permanent methods. Next slide, please. So in line with the discussion of today, our men have reached us clients, and I'll be elaborating in the next couple of slides how and what exactly we're doing, but also we engage them, as my previous speakers have presented, as partners and advocates of family planning. So next slide, please. This slide is just to mention that we use ecological model to map out the behavioral determinants so as we can better target at different level. We did this at the design phase and at implementation. Next slide, please. So for the men targeted services, this is men as clients using community approaches. So we work in the community at geographical hotspots in specific venues. We provide group and individual counseling for family planning, but this is also integrated with HIV services. We provide IC materials for family planning, sexual reproductive health in general, and HIV. We do condom distribution and condom demonstration sessions to build the skills of the men at the different spots, and also we do referrals for vasectomy. So the pictures there just show our teams working in some of the hotspots. We also work in the nights, we work in workplaces. Next slide, please. So one approach is to reach out to the men directly, but understanding that men or sexual partners of men are also a potential entry to reaching out the men. So we use a curricular-based approach led by peers to empower female sex workers who are clients to the men whom I mentioned in the previous slides, but also we empower adolescent girls, young women, so as they're able to reach to their sexual partners and empower them with knowledge and information to be able to better educate men on family planning and sexual reproductive health in general. Next slide, please. So having that information is one thing, but another part and parcel, as what my previous speaker presented, is where do we find the men? So what we do is in engagement with the men themselves at the geographical hotspots and peers, but also with their potential sexual partners, we do a mapping of the geographical locations. We go to the level of knowing what day of the week, what time of the day that we can get men at different hotspots. The pie chart on the right side just shows that for a period of January, February, for the men under age of 35, which apparently are part of our group, we were able to reach more than 70% of them through homes and through tents that are set at the mobile setup. Next slide, please. This slide, I'll ask you to skip it. Basically, it's showing we use peers and social media and SMS to create demand. Next slide, please. So for adolescent girls and women, understanding the dynamics of the partners are a little bit different. We engage in an exercise with adolescent girls, more than 2,000 of them, to help us map out who are their potential sexual partners and where do we get them. So out of this exercise, the pie chart on the left basically you're seeing these are the profile of the men whom they're engaging with sexually. So for us, this is a target for both HIV and family planning services. And the bar chart on the right, these are the different locations. So the services that we're providing target these locations, either be it for the men as clients, but also when we're looking for advocates, etc., etc. So next slide, please. So what about engaging men as supporters of family planning? Our community service delivery model, we're employing couple counseling approaches for sexual reproductive health and family planning. So this is one of our main entry to engaging men in the presence of women, so they're educated and better build the skills to be able to support their partners. But also we've engaged a team of community activators who would go around in the community, like the photo you're seeing on the down left corner. That's a man who has been trained on how to engage other men on sexual reproductive health, family planning, and they would move to the different hotspots that we've mapped. We do the same to help them address some untoward gender norms and gender-based violence. Next slide, please. Next slide. All right. So, and then the last one is engaging men as advocates. So, Raising Voices Uganda, they did develop a package for community-based, gender-based violence or violence prevention. And what we've done under Sauti is to adopt this package and contextualize it in the context of the population we're serving. So we ran out gender transformative dialogues and dramas at the communities that were working using some men champions and men who have been trained to engage other men, so as we increase demand and uptake for both HIV services and family planning. And in the same spirit, we're also engaging or sensitizing different leaders, police, the media people on the gender norms as it regards to sexual reproductive health, family planning, and HIV. And also being a community partner, under Dreams, we have also developed some materials that are targeting different men in the communities that we're serving. Next slide, please. So this slide is really to highlight that over a period of 2 years, we've reached more than 100,000 community members with the gender transformative messages. The beauty of what we do also is we do surveys periodically, so we are able to map out men at a particular location, what are their attitudes towards gender-based violence, etc. And we tailor our interventions and programming to those particular areas. Next slide, please. This slide, again, is just a quick highlight that for a period of August 2015 up to September 2017, we'll update this data more in future. We've reached several men for the typologies that I showed in the earlier slide, so about 130,000 distributed condoms. Also, large of them were partners of female sex workers, based on the focus of our program. Same applies to women of reproductive age groups. So the slide there just shows the number of pills, injectables, implants, and IUD referrals we've done. And again, as you can see, condom distribution, both female and male, forms the majority. Next slide, please. So basically, what I've done is just to give a quick highlight of, in our combination prevention program, as much as we're providing HIV services, we've integrated that with family planning. And we're engaging men and boys, both in terms of service provision, but also using them as a secondary audience to support and be advocates of family planning services uptake in the geographical locations that we're working. And as presented by my previous slides, my previous presenter, what we've done is really to integrate this information based on the framework that was presented to help men. So that's the end of it.
Great, thank you very much, Albert. So as you see, 3 fabulous contributions to this conversation. Thanks again to all the presenters for their hard work and their excellent programming and implementation. So we're going to move to questions and answers. They've started to come through thick and fast. You need to be careful what you ask for. I've tried to group some of them, the ones that we've received so far, and we've got about 15 minutes for conversations. I'll pose those back to the presenters, and then they can respond to the questions that they feel most would be most helpful for them to to speak to. So there was a question about the theorizing of male engagement. How are we theorizing it? Is there a problem with the way in which we theorize or look at it? And I know that Rebecca, you specifically kind of alluded to a very interesting point around the theorization of unmet needs, for example. So a question around theorizing, and Rebecca, there was also, I guess, not directly related, but somewhat related, a question about what do you mean by inhibiting, enabling masculinities. So a question kind of around that issue. And then secondly, I guess what I would say is questions around unintended consequences. So there was a question around the potential for intimate partner violence if these interventions are not appropriately taken forward. How are we ensuring that our male involvement work is effective and thoughtful? It's not just adding on men for the sake of it. It's really thoughtful in that. And then related to that was questions around the power dynamics. So how are we addressing power dynamics within couples, within societies? How are we thinking about that? And then third bucket, I would say, was a couple of implementation specific questions. So one around especially the how to work with female health workers, and recognizing that often health workers are not that well trained or supportive to be able to engage with men, and how are we especially working with health workers, especially female health workers. The person was asking, how are we starting early? How the importance of starting early within that, and then how are we being receptive to different geographical areas and the kind of different contexts within that, be economic, religious, cultural, etc. So let me take those questions first in the order of the speakers, if that's okay. Aaron, Rebecca, and then Albert. Please respond to whatever you feel you can, and then we'll come back if we've got time for more questions.
Thanks, Tim. Wow, those are great questions. We could talk for a couple hours on those. So let's see. Let me start with inhibiting versus enabling factors, since that's kind of a clarifying question. So what I was referring to are gender attitudes and norms that might either promote or impede whatever our outcome is. So in this particular project I was discussing, it was family planning. So maybe an inhibiting norm might be something like men who believe they need to, and this was the case for some men, that they want to have many children to kind of show their masculinity. An enabling one might be a norm about protection and caring for their children and being a good father. So simple, but kind of those are simple examples, but just the fact that, when we look at gender, it's going to have both, positive and it's going to present maybe positive things and barriers to our outcomes. In terms of theorizing male engagement, I think that's a really big issue, which I would not dare to answer, but I would just say maybe we need to be more explicit about it and more open about our different ways of approaching this work, and make it sort of the elephant in the room more visible. In terms of unintended consequences, that's a really great question, and I think we do try to build into all of our work very close monitoring and learning with all of our projects. So for example, in the work in Benin, we did do monitoring. For example, we had a radio program. This was conducted with Plan and Care in Benin, and there was a radio call-in program. And as we monitored, we got transcripts of the calls, and we started looking at that, and we found that a lot of the calls were reinforcing very harmful masculinities, I would say, in terms of what our project was aiming for. But because we didn't have the resources or the structure to have some kind of a monitoring person on the call-in program, we ended up just eliminating that element of the project rather than continuing with it. So we never really would have known that except for some kind of qualitative research that we structured in. We also build in maybe 3-month, 4-month check-ins where we do kind of different kinds of mappings, most significant change, and we bring together stakeholders to talk about how they're seeing the project going. Are we achieving our goals? Are we not? And what are some of the unintended consequences? Because there often are some, and sometimes they're positive, but they can also be negative as well. And then build in that iterative learning and action loop to adjust the intervention or the program accordingly. Starting early, I think a lot of our work, as some of you might know, is focused on 10 to 14-year-olds and really trying to work, for example, work in Nepal with Choices and Choices, Voices, Promises, Growing Up Great, all the great projects in Uganda, the Growing Up Great in DRC, all focused on working with younger children around gender and gender norms and gender equality. So I think that's really critical. And there is an ongoing study around the world, the Global Early Adolescent Study, which is following young people, and DRC is one site, for 5 years to see how gender socialization rolls out and what is the long-term effect of early intervention on gender and other health outcomes as the young people grow up. I guess lastly, how to be receptive to different contexts. I would answer that with the scale-up lens, and in fact, the idea that we test programs, we say they're successful, we say they're evidence-based, but that doesn't mean that they're going to work in the same way in a different context. So being very sensitive and thoughtful and careful about adapting interventions and adapting interventions in new settings to make sure that we really understand how these programs are working, what are their pathways of change, who are they benefiting in what ways, and who's being benefited by them in what ways and what settings. So a lot of, I guess, really folding in a lot of learning and thoughtful qualitative work along with our interventions as part of our implementation science work. And power dynamics, of course, is at the root of all of it. And I guess the only thing I would add, I'm sure others have more to say with this, is that it starts with us, right? So it starts with those of us who are developing projects, who are doing the research, our staff that we're training, our partners on the ground. So we really have to, use, CARE's work about, beginning by looking within before we start to, put these gender transformative programs or working with men or women out there kind of on the street.
Great, thank you. Erin?
Great, thank you. I'd like to jump in and touch on a couple of the issues that were raised. First, I'd like to say, sort of encompassing a lot of the approaches that we've talked about, we really emphasize that our programs are grounded in principles of voluntarism and informed choice and quality of care. And this means we're supporting men, women, and couples to make informed decisions about the timing and spacing of their children based on their own individual reproductive intentions. And part of how we help to achieve that is by thinking holistically in the way we program our activities. So, we're not just on the one hand trying to drive up demand without really enabling the service providers or the health system to be able to respond to that demand. So we really look at multiple levels and program components, so supply, the demand, and the enabling environment. And so coming to the question that was specifically about the balance of female health workers to male workers and how to better reach men, if the government has a limited budget to hire more male health workers, I think a key point is that there are lots of ways to help strengthen the capacity of the health system to deliver quality services to men, boys, and couples. And so for one part, it's really addressing the bias of decision makers and healthcare providers so that they can have values clarification and supportive supervision and coaching to encourage them to change their expectations of men in their role in family planning, and in order to, for example, to enable couples counseling in the context of other health services where they might currently only be reaching women. And in addition to that, that includes acknowledging the sexual and reproductive health needs of adolescents. So providing male-friendly family planning and reproductive health information and services where and when they need it. Another aspect of programming is to really think creatively about how to do outreach to men and couples through multiple channels. I think we've already heard great examples from Tanzania and from a range of projects that Rebecca discussed, where multiple channels are used to reach men and boys, including radio, community events, range of providers, male and female counselors or educators, and through those approaches demonstrating equitable communication. So I'll stop there.
Albert?
Right, so mine I think has been well addressed, but basically I would like to pick on engaging or working with female workers. What works very well in this kind of programs is to appreciate the fact that men is and boys are a very diverse group. So we've done a couple of focus group consultation or discussions with our beneficiaries. And when asking them whether they would prefer to be seen by male or female beneficiaries, there's a wide range. There's some who like to be seen by male providers, some female, some do not really care which one is which. Talk about peer educators who are raising or creating demand. Some prefer male, some both, some it does not matter. If you talk about locations, a couple of them would prefer to be reached at the places where they're congregating. And when it comes to facilities, I think what really matters is what my colleague has also explained, is how do we make these facilities friendly and accommodating. So what I feel is there isn't a one-size-fits-all to how we can encourage men to better participate in services. We have to combine. We need to differentiate. We need to give all the options available. So in my project, we have male providers, female providers. So we have a menu. If someone prefers to be seen by a male, then we have that provision. We have male peers, but also what we've done recently, and this is very much informed by work that one of our partners in gender health did a couple of years back on the Men as Partners program. We have developed some health-friendly services assessment tools, and we assess facilities together with folks from the ministry. So we have standards for that, and then we are training providers and build their capacity so as they're able to provide friendly services. So in some aspects, female workers could matter depending on the typology or that specific group of men who prefer, but otherwise really tackling it at different facets is going to be very key to making sure we reach out to every man and provide them with services they require. Thanks.
Great, thank you for those. Quickly, in terms of some other issues that have been raised, and I'll give each of the presenters a moment, 30 seconds if you can, to respond on these. So questions around funding that often comes up. Is this work taking resources away from work with women and girls? But also actually another response saying, well, do we have a sense of, out of the overall funding priorities, how would you rate male engagement in FP? Is it a funding priority? A few questions specifically on men as users. How do we increase men's uptake as users, but also in particular, how do we broaden the method mix for men? And comments around the fact that there is a less limited set of methods for men than there are for women, and how do we broaden that? And then a third question around linkages. So linkages between family planning and HIV STIs, and also linkages to other programs, WASH programs, other approaches. Quick thoughts from the panelists on those. Before I jump to them, just to say a number of people have asked about receiving copies of the slides, receiving the recording. Are the materials of organizations available? And just to say, yes, you will. This is being recorded. You will receive a copy of it. The slides are all available, and all of the presenters included, I believe, their website and their email address. And I know that from all of the organizations, their materials are available on their website, and I'm sure they'd be more than happy to share more about their work. So quickly on those three questions, if we can go in the same order, beginning with you, Rebecca.
Okay, thanks, Tim. I'm going to tackle the funding question. So I really don't see this as a zero-sum game, because I think if we look at our objectives and our outcomes, it takes both men and women to get there. And for example, none of the projects that I mentioned did not address women also. So I'd really kind of encourage us to think about gender synchronization and where do we want to get to and how can we get there engaging both men and women. So I don't think, although I didn't talk about the female parts of those projects, women were engaged as well, even in the Real Fathers project. So I'll leave it at that.
Great. Erin?
Sure. So as well, on the relative priorities of addressing men and boys versus women, equally, as Rebecca said, I don't see this as, it's only one or the other. In fact, they're very complementary approaches. And as far as within a given context and prioritizing interventions, I think really those decisions need to be based on the needs analysis of what are the barriers already in place. And typically you'll find that if you're not addressing men, well, then you're not really addressing some of the root causes or the barriers for improving access, availability, and quality of care for all the clients you're trying to reach. So really decisions like those need to be data driven, but also as Tim mentioned, I think up front, we're not just talking about doing this because it's right, but also because it's effective. So it's important to really look at the data and see where the opportunities are, where the gaps are, and then apply these approaches where they make sense, where they fit with the intentions of your program. Thank you.
Great. Albert, any thoughts on the linkages question and broader male method mix?
Right, so I'll pick the linkages one. I think our consultation with the men beneficiaries and the other groups that I mentioned, usually there is a need for a greater menu or a comprehensive package of services. We have the advantage in the project that I'm working on that besides HIV testing and treatment and family planning, but also we're providing STI screening, alcohol, drug use, tuberculosis. We have STI periodic presumptive treatment for the high-risk ones. Now HIV self-testing. I would sum up by saying that men do require services beyond one piece, be it family planning or HIV. And the more you have a larger package or your menu of package comprises of different elements, they kind of serve in creating demand for each other. So it's very practical to us as a project. As we are providing this range of services, it helps with increasing uptake of either. So that would be my answer for now. And the other question was on, remind me, Ados.
It was on the need to expand the male method mix of contraception.
So I think it's sort of been highlighted already. Men, as we are serving them in the community platform that I've explained, based on the limitation that we only can provide condoms and the rest you have to refer to the facilities, I think kind of acts as some kind of a barrier, but I believe with our plans to increase family planning uptake, we need to work around these kind of problems. I believe the best one would be to bring services much closer and look at some of our policies that could hinder provision of such of these methods at the community, for instance.
Great. Thank you very much. We are now over time. There's a number of questions I realize we didn't get a chance to answer. We will have a look at them. If there is a possibility, we'll try to respond to those. Please do reach out to the individual presenters and to the organizers for specific follow-up. Please do download the HIP high impact, the guidance brief strategic planning guide on this issue, and you can see on the slide in front of you, as mentioned, the web address for the HIPS, highimpactpractices.org, for the IBP, and for Family Planning 2020 and our global goal together to increase uptake of methods. Please join me in thanking all of the presenters. Thank you for everyone for staying. I think we recognize just how important this issue is, and as all of the presenters said, I think it's critically important that we strengthen these approaches, that we take them to scale, that we deepen the focus within our work on male engagement, and I hope that this can be the beginning of ongoing conversations and support to do that. So thank you very much for staying with us, and yeah, stay tuned, stay in touch, and look forward to further conversations. And thanks also to the organisers for making this happen today. And yeah, thank you again. Bye bye.